This conference will now be recorded.
Hello everyone, can you hear me? You can unmute your mic and please tell me that's whether you can hear me or not.
Yeah, we can hear you. I can hear you.
Okay, so I welcome you to this session. I am Dr. Jhuma Vishwas and I am the one of the mentor of MRCOG Health. And today I will going to discuss one of the important topic and it's a recent talk. It's talked April 20 and this is management of ovarian cyst in children and adolescents. So why you need to read this talk? As because you know that there's two GTG guideline. One is ovarian cyst in management of ovarian cyst in premenopausal women and postmenopausal women. But there is no guideline for children and adolescents, though it's very common in this age, and most of the case it's a benign and malignant are very rare. So most of the cases we can manage ovarian cyst in children and adolescents conservatively, and if we diagnosed early, then even in the malignant case, we can if we diagnosed early, we can manage properly. Then survival rate is very high, like more than 90% of the cases. So that's why you need to read this talk. It's if you read the management of ovarian cyst in premenopausal women, management is little bit different in ovarian cyst in children and adolescents, because as I told you that majority of the cases it's benign in nature, and the type of the ovarian cyst is also different. So let's start today's topic. So ovarian cyst you can see in the girls and women of all of the ages. It's the one of the commonest tumor, or it's one of the commonest cyst in female reproductive organ. And in children and adolescents, its peak incidence can occur in first year of life. You can see that in the first year of life, the ovarian cyst incidence is very high, and also around the time of menarche, because at that time hormonal changes occur, and majority of the cases cysts are functional, like the follicular cyst. And most cysts are benign and will resolve spontaneously, as I told you, and they can present with pain. That means some of the case you can see that patient come to you with pain, or that may be milder or that may be severe, but usually they are an incidental findings. That means it's only diagnosed when we do ultrasound for other reasons. That means if we do any ultrasound for any pain or any kind of any other things, then we can found this ovarian cyst. Risk of malignancy is low. However, the possibilities of malignancy means that ovarian cysts in children and adolescents are often overtreated with unnecessary surgery. So, as the risk of malignancy is very low, but there's if we suspect that is an ovarian cyst, it's malignant, then sometimes we can do some over treatment and unnecessary surgery in case of adolescents and children. Even sometimes we can do laparotomy and oophorectomy, though it's not necessary in case of in this age. So first we will discuss neonatal ovarian cyst. And in ovarian cyst are the commonest cause of abdominal cyst in female fetus. So if you see any cyst in the abdomen, majority of the cases it will be ovarian cyst, and it's presenting in the third trimester. So most of the cases you can see this ovarian cyst in female fetus in third trimester of the pregnancy, and most of the cases these are unilateral, simple in nature, and they can be varying size. That means it's majority of the cases it can be localized to one ovary, and it's very simple in nature, and its size can be varying like small size to moderate in size. And why this ovarian cyst is common in neonatal age? Because of fetal gonadotrophin, maternal estrogen, and placental human chorionic gonadotrophin. These hormones are responsible for formation of ovarian cyst in female fetus. So this cyst can cause some complications, like it can cause rupture, torsion, hemorrhage, and compression of nearby structures. And volume of the ovary usually in the first year of life it's only 1 ml. Reduction of the estrogen level, as at birth most estrogen is the maternal in origin, reduces the size during the second year. That means You can see these cysts are functional and it's unilateral and it's simple cyst. Most of the cases is present in the third trimester. It is due to presence of hormones like maternal estrogen, gonadotrophin, and placental human gonadotrophic hormone. But at the second year of life, as these estrogenic support, as you know that these estrogenic support are come from maternal source. So as these supports are not there, so due to reduction of estrogen level in the body, these cyst size also resolve. And follicles can be seen in 84% ovaries in the girl under the age of 2 years. So below 2 years, you can see majority of the cysts are follicular cysts because of hormones, that is maternal estrogen. Most of these regress spontaneously, but this can take several months. That means, as I told you, that due to the reduction of estrogen level, because it's come from a maternal source, due to reduction of this level, the majority of the cases this can resolve, and that's why majority of the cases there is no role of any treatment. So management is often conservative and may involve serial scan, but if the cyst is very large or if torsion is suspected, then surgical management is considered. That means as it resolves spontaneously in majority of the cases, only serial scan you can do. There is no role of doing any intervention like laparotomy or laparoscopy. But if you see that the cyst is very large or if the torsion is suspected, in that case you can do surgical management. Just a minute. Okay, so if you see that its cyst is very large and there is an if you suspect that there is a torsion, only you can do surgical intervention. Otherwise only serious scan you can do to confirm that the cyst is completely resolved. So in case of ovarian cyst in adolescents and children, it can be benign ovarian cyst. So you can see the types of cyst in here. So you can see that majority of the cases is benign and it can be malignant in 4 to 16% cases. That means it's very rare. And among the benign tumor, it can be simple or it can be complex. So simple cyst, it's occur in majority of the cases. You can see that means in ovarian cyst in adolescent girl, majority of the cases these are simple, like 60% of the cases, but it can be complex, like it can be mature cystic teratoma, endometrioma, gonadoblastoma, serous cystadenoma, mucinous cystadenoma, and cyst adenofibroma. And there is an also chance of torsion. There is an also chance of tubo-ovarian abscess, paratubal and para-ovarian cyst. But majority of the cases it's simple, like you can see 60% of the cases. And in case of malignant one, 4 to 6% cases it can be malignant. So it can be a sex cord stromal tumor, it can be a germ cell tumor, it can be of epithelial tumor. So in sex cord stromal tumor, it can be juvenile granulosa cell tumor, it's most common, and Sertoli Leydig cell tumor. And among the germ cell tumor, majority of the cases can be dysgerminoma, it can be yolk sac tumor, it can be embryolal carcinoma, polyembryoma, or immature teratoma. And among the epithelial tumor, though it's very rare in children and adolescents, so but if it is occur, it can be serous or it can be mucinous adenocarcinoma. So you can see that majority of the cases cysts are benign in nature and 60% are functional simple cyst. And a study of premenstrual girl present with pain showed the incidence being 1.8 to 15% with an increased incidence with age. That means majority of the cases patients are asymptomatic, but it can be present with pain like in 1.8 to 15% of the cases. And one of the commonest cause of this pain is cyst rupture, and it's a common adolescent findings at laparoscopy for an acute abdomen in young girls. That means it's a commonest problem of or commonest cause of pain of ovarian cyst, that is ruptures, and in these cases there's no requirement of any kind of intervention. So if you see in the laparoscopy, that's there's a rupture of ovarian cyst, there's no role of any kind of intervention. So I told you that it can be a paratubal cyst. So sometimes it can be confused with a simple ovarian cyst, but this paratubal cyst can grow quite large and they do not resolve like ovarian functional cyst. That means it will be a persistent cyst. It can be resolved like a functional ovarian cyst. If you do a follow-up scan, in that case, you can see paratubal cyst is increasing in size, is quite a big in size, and it can be resolved like a functional ovarian cyst. In case of postmenarchal girl, they may face mid-cycle pain and often associated with functional hemorrhagic cyst. As because of ovulations, they may face mid-cycle pain if the adolescent girl are postmenarchal, and this may be associated with some free fluid and hemoperitoneum, and majority of the cases that also resolve spontaneously. So in this case also you need a follow-up scan after 4 to 6 weeks, but there is no role of any intervention. So it can be a complex benign cyst, as I told you, that it can be a mature cystic teratoma, endometrioma, gonadoblastoma, or serous or mucous adenoma. So most common complex benign cysts can occur in children and adolescents are germ cell tumors. And in among the germ cell tumor, majorities are dermoid cysts, that is mature cystic teratoma. It can occur in 55 to 70% of the cases. So you know that in postmenopausal women, ovarian cyst, majority of the cases they can be cancerous, and in premenopausal women, majority of the cases ovarian cyst can be benign, it can be germ cell tumor, or it can be a borderline ovarian tumor. But in children and adolescent girl, majority of the cases cysts are benign and they are functional, and if they are complex in nature, that can be germ cell tumor, and among the germ cell tumor, majorities are dermoid cyst. And this complex benign cyst, this germ cell tumor, most of the cases is occur between 6 to 15 years of age. So you can see that this type of cyst like dermoid cyst can occur in 6 to 15% of 15 years of age, and the majority of the cases, like you can see the 10% of the cases, they are bilateral, and they are usually asymptomatic and are discovered incidentally on ultrasound scan. These dermoids, they do not produce any kind of symptoms. Some of the cases they can produce mild pain, but majority of the cases they do not produce symptoms. These are asymptomatic, and 15% of these dermoid cysts, as I told you, they can present with pain or they can present with torsion, because torsion is quite common in dermoid cysts. And spontaneous ruptures of mature cystic teratoma can occur is very less, like less than 1% of the cases, and malignant transformations that can report like 1.7%. That means you can see majority of the cases these dermoid cysts are asymptomatic, and but they can produce pain, they can cause torsion, and the rupture and malignant transformation is quite uh, rare. And they can also present with some rare medical complications, like they can present with carcinoid tumor, stroma ovaries, hemolytic anemia, and anti-NMDA receptor encephalitis. These NMDA receptors are responsible for our memory cognition, so dermoid cysts can produce this rare type of complications. And another form of complex on ovarian cysts are the gonadoblastoma, that is mixed germ cell tumor. And usually this type of problem occur in gonadal dysgenesis case. That means if the female gonads carries any Y chromosome, in that case they produce this gonadoblastoma. That means in case of androgen insensitivity syndrome, as you know, the gonads are the testes, so there's a chance of gonadoblastoma development. Although benign, and it can be evolved into dysgerminoma with malignant features. That means it can be a gonadoblastoma or it can be a dysgerminoma with the malignant features. Next is malignant ovarian tumors. These are very, very less common. That means it's very rare, not that much common. So among the malignant ovarian tumor, the most common are the juvenile granulosa cell tumor. So in adolescents and children, the most common malignant ovarian tumors are juvenile granulosa cell tumor. Another one is malignant ovarian germ cell tumors. You can see that the half of the malignant ovarian tumors in children and adolescents are juvenile granulosa cell tumors. That means 50% of the cases malignant ovarian tumors are juvenile granulosa cell tumor. And as you know that it's a sex cord stromal tumor and it's a solid tumor, and it's a 50%. That means half of the cases is diagnosed between 6 to 13 years of age, and one third of the cases is diagnosed between 14 to 19 years of age. And over 50% of the patient present with with a tumor limited to the ovaries, and more than 90% survival rate with surgical resection. That means it's a majority of the cases it's localized in the one ovary, and if you remove the ovary, more than 90% of the cases survival rate increases. So that means it's a follow-up schedule. If you do the follow-up in case of malignant ovarian tumor, these juvenile granulosa cell tumors, their prognosis is quite high in case of children and adolescents years. And majority of the cases, these are unilateral. In 2 to 5% cases only, these are bilateral. And as you know, these granulosa cell tumors can produce estrogen, and also it can produce androgen. So majority of the cases they present with pseudo precocious puberty, like pigmentations of the breast areola, breast engorgement, and vaginal discharge and pubic hair due to release of estrogen hormone. They present with this type of features. And these juvenile germ cell tumors or granulosa cell tumors are mainly estrogen secreting tumors, but can be also release of excessive androgenism, such as that's why they can produce other like androgenic features like clitoral enlargement, hirsutism, deep voice, irregular periods, and amenorrhea. That means most of the cases these granulosa cell tumors produce estrogen, so they may face problem like pseudo precocious puberty, but some of the cases they can also produce androgen. So if they produce androgen, features are like androgenic type like clitoral enlargement, hirsutism, deep voice, irregular periods, and even amenorrhea. So this is the one of the commonest malignant ovarian tumor in children and adolescents, that is juvenile granulosa cell tumor. The next is malignant ovarian germ cell tumor. So it's very rare in ovarian cancer in the Europe in this age, like 1.5% of the cases. And among these malignant ovarian germ cell tumor, one third of the cases these are dysgerminoma, one third of the cases it can be immature teratoma, and one third of the cases it can be embryonal tumor, endodermal sinus tumor, choriocarcinoma, and mixed cell tumor. So it can be dysgerminoma, it can be immature teratoma, or it can be other germ cell tumor. So immature teratoma can be defined as presence of variable amount of immature neuroepithelium. So within the immature teratoma, they may contain immature neuroepithelium inside that. And most of these malignant ovarian germ cell tumors are occur in first 2 decades of life, and early diagnosis and multi-agent chemotherapy are associated with high cure rates, and risk of premature ovarian insufficiency is very less, like about only 3% of the case. That means if you are diagnosed earlier, if you treat with multi-agent chemotherapy, success rate is very high, and there is a very less chance of premature ovarian insufficiency. Okay, so you can see if we revise this one, so you can see that most of the cases are benign. Among the benign tumor, simple cyst is quite common, like 60% of the cases, and malignant, it can be malignant in 4 to 16% of the cases. And among the malignant ovarian tumor, it can be juvenile granulosa cell tumor. This is the commonest one, or it can be malignant ovarian germ cell tumors. And in among the malignant ovarian germ cell tumors, one third can be dysgerminoma, 1/3 can be immature teratoma, and 1/3 can be other ovarian germ cell tumor. And another important thing in complex ovarian tumors can be germ cell tumor, and it can be also gonadoblastoma or dysgerminoma if they contain Y chromosome in the gonads. So up to this, anybody have any questions? Okay. So next is how this ovarian cyst present in children in adolescent age, and what are the differential diagnoses are present in this case. So as I told you that majority of the cases, these are asymptomatic, that is they can present with an incidental findings, or they can present with some various symptoms, and 30% of the cases they can be present with pain. That means pain is also quite common problem. Okay. And uh, incidence, it can be also present like an ovarian torsion, and overall incidence of this ovarian torsion are variable like in 7 to 10.5% of the cases, and mean age of torsions is 9.5 to 12.5 years, and more common on the right side. So one of the it can be present as an asymptomatic, it can be present with the pain, or it can be present with torsion. So in torsion, the commonest age of torsion is 9.5 to 12.5 years, and it's most common in right side. Why it's common in the right side? As because you can see in the right side there is a mobile cecum. So this mobile cecum can permit the movement of the cyst, and its evidence shows that mesosalpinx and ovarian ligaments on the right sides are quite longer in comparison in the left side. Okay. And in the left side there is a fixed sigmoid colon, so that limit the movement of the cyst. So that's why it's quite common, this torsion is quite common on the right side. And it can be present with abdominal distension if the cyst is very large, and these large cysts can also be present with pressure symptoms, urinary frequency, pain, and even breathlessness. And very rarely, like if it is a fibroma, thecoma, or granulosa cell tumor, it can be present with hydrothorax or non-malignant ascites. We know, you know that its name is mixed syndrome. So mixed syndrome occur in these three tumors. One is fibroma, thecoma, and granulosa cell tumor, but in this age it's quite rare. So what the commonest symptom can present, one is it can be asymptomatic or incidental. It's quite common. It's 30% of the cases it can be present with pain, so it's common. Abdominal distension or any effects of abdominal mass, it's less common. Weight loss, polymenorrhea, menorrhagia, precocious puberty. If it's a granulosa cell tumor, so it can be present with this, so it's quite less common. And dysuria, constipation, leg pain, or limp is unusual. It's mostly occur in a very large cyst. Fever, nausea, vomiting, back pain seen in the ovarian torsion. Ovarian torsion is quite common in 9.5 to 12.5 years, and also in the right side. So these are the differential diagnosis. So they divided it according to the age. So in the neonate, it can be a UTI, it can be a Hirschsprung enterocolitis, it can be incarcerated hernia, it can be intersubsection, it can be a Michel's diverticulum, or even it can be a volvulus. In the children, it can be appendicitis, it can be gastroenteritis, it can be mesenteric adenitis, it can be ovarian pathology, pneumonia, constipations, and urinary tract infections. It can be anything. Okay. And in the adolescents, it can be appendicitis, it can be diabetic ketoacidosis, cholecystitis, gastroenteritis, ovarian cyst, ectopic pregnancy, hydrosalpinx, PID, renal calculi, and UTI. So when a patient present with you this type of problem or any kind of pain, so in that case you have to rule out the other problem like any urinary problem, any bowel problem, and even any GIT problem. Even if it's you have to rule out appendicitis as well, because if you suspect that is a torsion, and most of the cases torsion are occur on the right side, so it can be appendicitis. So also you need to rule out these things. So when there's a cyst, we need to rule out these things. And as you know, to diagnose the ovarian cyst, to see the nature of the ovarian cyst, the most commonest way is to do the ultrasound. So children and adolescents, as if they are mm, in this case, children and adolescents, in this case, we have to do trans-abdominal pelvic ultrasound. Okay, if they are sexually active, in that case, we can do the transvaginal ultrasound, but otherwise, we need to do a trans-abdominal pelvic ultrasounds, and its sensitivity and specificity is quite high, like 94.4% sensitivity and 98.2% specificity. So do you know what is sensitivity and specificity? Sensitivity means that it's the ability of any test to diagnose the positive case, though are actually have the positive one. Okay, that means they are actually have the diseases. And specificity means that they rule out the asymptomatic patients, though actually do not have the diseases. So that's called the specificity. So in here you can see that transabdominal pelvic ultrasound, both the sensitivity and specificity is quite high. So this is the first line investigations you have to do in case of ovarian cyst in children and adolescents. And if you suspect that it's a complex ovarian cyst, so in that case, you can do an MRI to rule out the nature of the this tumor. Okay, and other test you can be do with an with for as in to find out the other problem, like you can do the full blood count, you can do the C-reactive protein, you can do tumor marker. As you know that if the age of the woman is less than 40, in that case, most of the cases these are the germ cell tumor. To germ cell tumor we can be diagnosed with a tumor marker. So in this case also we can do the tumor markers. One is alpha fetoprotein, ACG, lactic acid dehydrogenase, cancer antigen 125. And to rule out the infections, we can do the urine dipstick test if it is indicated, or if you suspect that it can be an urinary tract infections, you can do that. And if you suspect that it may be an pelvic infections, like if the patient is sexually active, in that case, you can do an endocervical swab for pelvic infection rule out. Okay, and if you suspect that, or if you see that there is some signs of precocious puberty, so in that case, you need to do hormone profile. In that case, you need to do FSH, LH, estradiol, and even also you need to do the thyroid function test if it is indicated. So these are the guideline of investigations you can do in adolescents or children if they having any ovarian cyst. So I think you all know this B rule, M rule. So in ultrasounds, if you see this type of features, we can classify them as a B rule, M rule. B means benign and M rule means malignance. Okay, so in B rules, if you see that these are the features, if you find, then you can diagnose these are benign in nature, like if the cyst is unilocular, or there is in presence of any solid component with the largest being less than 7 mm, or if you see that presence of acoustic shadowing, mostly if they contain any solid material like teeth, bone, as it's present in the dermoid cells, in that case they can show acoustic shadowing. So if you see any acoustic shadowing, so it's confirmed that is a mature cystic teratoma, so it's benign. If you see any smooth multilocular tumor with largest diameter is less than 10 centimeters, and blood flow absent on the Doppler, blood flow mainly present in malignant case. So if you see it's absent, so you can confirm it's a benign in nature. So in the M rule, if you see it's an irregular solid tumor, there's an ascites, there's an papillary structures, and at least 4 in number, and there's an irregular multilocular solid tumor, and the largest one is more than 10 centimeter, and very strong blood flow present. So you can suspect that it can be a malignant one. So by this way, this international ovarian tumor analysis, by this way you can classify them as a benign, or you can classify them as a malignant by doing trans-abdominal pelvic ultrasound. And these are the tumor markers, and these are specific for type specific type of, these are very specific for specific type of ovarian neoplasm. So you can see here alpha pretoproteins are can be raised in immature teratoma, sertoli cell tumor, York sac tumor, and embryonal carcinoma. ACG can be raised in dysgerminoma and embryonal carcinoma. LDH, that is lactate dehydrogenase raised in dysgeminoma and immature teratoma. Cancer antigen 125 can be raised in epithelial tumor. CEA, that is carcinoembryonic antigen raised in epithelial tumor. Estradiol raised in juvenile granulosa cell tumor. Testosterone raised in Sertoli Leydig cell tumor. So the main thing is that they can give you one tumor marker and they can ask you that in which tumor it's raised. So you also need to know these things. Okay, so before going to this chart, we can go through this management. So as I told you that the most of the ovarian tumors are benign in nature, so their management is mostly conservative without any kind of surgical intervention. Okay, so when you do the interventions, you need to see the size of the tumors and also the nature of the tumor. So if you see that it's a simple cyst less than 3 centimeter in diameter, so in that case, no further imaging is required. Most of the cases, these are the follicular cyst. It can be resolved spontaneously, so there is no role of doing any further imaging. But if you see that the cyst diameter is 3 to 5 centimeter, in that case, you need to arrange a 3-month checkup for resolution. And if you see that it's completely resolved, then there's no role of further imaging. Okay, and if you see that it's 5 to 7 centimeter in diameter, so offer surveillance ultrasound in 3 months. Then either you can do a further ultrasound in 3 months, or you can arrange for laparoscopic ovarian cystectomy if patients are is systematic. In that symptomatic, that means if the patient is symptomatic, in that case you can arrange for operation like laparoscopic ovarian cystectomy. Otherwise, you can do a ovarian surveillance in 3 months. Okay, so according to the size of the tumors, you need to arrange the management. Like less than 3 centimeter, no role of imaging. 3 to 5 centimeter, surveillance in 3 months. 5 to 7 centimeter, surveillance in 3 months. Or if the patient is symptomatic, in that case, you can arrange for laparoscopic ovarian cystectomy. But if you see that it's an hemorrhagic cyst, as I told you that in post-menarche woman, it can be an mid-cycle pain due to any hemorrhagic cyst. So in that case, you need to do a further scan in 6 to 8 weeks to check for resolution. So in hemorrhagic cyst, you need to do further scan in 6 to 8 weeks. Okay. So most mature cystic teratoma grow very slowly, like 1.8 mm per year. So it can be monitored conservatively. So if you see it's a complex cyst and it's a mature cystic teratoma. So previously we thought any kind of mature cystic teratoma, we need to remove it. But nowadays in children, adolescents, as I told you, we need to be think more conservatively. So as it's growing is very slow, like 1.8 mm per year. So in that case, you can monitor conservatively. And with laparoscopic ovarian cystectomy, especially for the mature cystic teratoma, the main risk is intraoperative cyst rupture, and there is a chance of chemical peritonitis is less than 0.2% of the cases. So as you know that in children and adolescents, our mode of operations that will be laparoscopic instead of laparotomy. So in laparoscopic ovarian cystectomy, especially for mature cystic teratoma, there is a chance of a cyst rupture. And as you know that these cystic contents are very irritant, so that can cause chemical peritonitis, and it can occur in mature cystic teratoma in less than 0.2% of cases. And there is an also chance of recurrence, especially for mature cystic teratoma, and that will depends upon the some factors, like if the patient is very young, if the cyst size is very large, or if it is bilateral, there's a chance of recurrence is more. So these are very very important for your exam. So if you see whom the risk is more, one is if the age is very young, if the person is very young, or if a very large cyst, or if you see that it's a bilateral one, the chance of recurrence is more. And previously we thought in dermoid cysts we need to do an operation, but as we see that the rate of growth is very slow, like 1.8 mm per year, so you can do a conservative management in this case. And as you know that if we do any kind of intervention, our mode of operations will be laparoscopy. So laparoscopically when we do the operations, in case of mature cystic teratoma, chance of rupture is more, and there is an also chance of chemical peritonitis, but these are rare, like in less than 0.2% of cases. Okay, and if you see that there is a torsion, so in torsion, you need to do a prompt investigations and interventions to avoid any long-term damage and prevent oophorectomy. So if you early diagnose it, then you can, if you do the intervention earlier, so you can avoid long-term damage and also you can prevent oophorectomy. So now our current recommendations for torsion is the torsion with or without cystectomy. It's very, very, very important. Previously, we thought in case of torsion, we need to do oophorectomy, but nowadays, our main recommendations of torsion is to detorsion with or without cystectomy, even if the ovary looks necrotic. Even you see that the ovary look necrotic, in that case also you can do only detorsion with or without cystectomy. So ovarian function has been proven in multiple study following detorsion of a blue black ovary. Even your ovaries, if you see that the ovaries are blue black, that means severely necrotic. In that case also there is a role that you need to do a detorsion with or without cystectomy. That means there is no role of oophorectomy because evidence shows that that can resolve ovarian function. So in that case, in adnexal torsion, main thing is to you have to do the detorsion. And gonadopexy, that means oophoropexy after detorsion, can be considered, especially with previous oophorectomy and the presence of unilateral torted ovary. That means if you see that is a recurrence one, or and it's an unilateral torted ovaries, that means it's only ovaries. In that case, you can do the oophoropexy or gonadopexy to prevent further torsion. Okay, so for the torsion, main management is the detorsion with or without cystectomy. There is no role of oophorectomy. Okay, so we can see this management protocol. Okay, so if you see that there is an ovarian cyst, so you have to do the referral and you need to see the presentation for ovarian cyst. If you see that, so if you see that patient is asymptomatic or there is a pain or patient may suffer from menstrual problem or any precocious puberty symptom, anything of that, in that case you have to first investigations you have to do, that is trans abdominal ultrasound scan, and according to that you have to manage. So I already told you, if it is a simple cyst and the size is less than 3 centimeter, remind it, if the size is less than 3 centimeter, there is no role of further scanning. But if you see that the size is 3 to 5 centimeter, in that case you have to do a rescan in 3 months for reassurance. And in premenarchal girl review in specialist, it's you have to do this test um, in you have to do this test in pediatric and adolescent clinic. That means your this scan you have to perform in a specialist clinic, that is pediatric and adolescents gynec clinic. Okay, that means if a simple cyst 3 to 5 centimeter, you have to do the rescan in 3 months. Less than 3 centimeter, there is no role of further rescan. If you see that it's a simple cyst 5 to 7 centimeter in diameter, and if it is asymptomatic, so in that case you can do a rescan, and if it is resolved, so it's okay. If it is persistent, then you have to do further investigations. But in this case, if you see that it's a symptomatic one, then you need to do the further scanning and MRI. Okay, that means 5 to 7 asymptomatic, you only need to do a rescan. If it is resolved, okay, but if it is persistent, then you need to do the tumor marker and MRI you can do. In case of symptomatic, you need to do the further testing. But if you see that the size is quite large, like more than 7 centimeter in diameter, in that case you can do laparoscopic ovarian cystectomy, or rescan in 3 months can be considered if asymptomatic. That means if the size is more than 7 centimeter, either you can do the scan in 3 months or you can directly go for laparoscopic ovarian cystectomy. So make it clear, like more than 7 centimeter, you can go for intervention like operation, or you can do the rescan. But below that, you need to follow up this, follow up that tumor. And if you see that in 5 to 7 centimeter, if it is symptomatic, in that case you need to do further investigations to rule out the nature of the tumor. So this is for simple cyst. Okay, and if you see that it's a complex cyst, so you know that it complex if most of the cases it can be a germ cell tumor, so we need to do some tumor marker test like alpha fetoprotein, HCG, LDH, and CA125 as we are doing in premenopausal women. So we need to do in this here also, and if it is required, like if the nature is not confirmed by ultrasound, so you can do an MRI. Okay, and no suspicion of cancer. That means if you confirm that it's not a cancer, but the patient is symptomatic, size is more than 5 centimeter, you can go for laparoscopic cystectomy. And all children and young girls should be followed up after surgery to discuss findings and implementation on future fertility. Okay, so in case of complex cyst, if you see that it's a first you need to do the tumor marker test, and if you rule out the cancer, in that case there's no role of any kind of treatment. But if you see that the patient is symptomatic, size is more than 5 centimeter, in that case you can go for a laparoscopic cystectomy. After operation, you need to do a follow up, and you need to inform the patients about the findings and also also the implementations on future fertility. But if you suspect it a cancer, as you know that in any cancer, we need to refer the case for to the MDT for further evaluations. Okay, so this is for simple cyst and this is for the complex one. Okay, and if you see that it's an acute abdomen, like if you patient present to you with a acute abdominal pain, so you may suspect that it may be a torsion. So in that case, you need to do an imaging to perform a surgery if available within 4 hours of admission and clinical condition permits. So if our clinical condition permits, and if you can arrange an ultrasound within 4 hours of our admission, so you can do that. Otherwise, you can directly go for laparoscopic surgery, whether where possible, or ovarian sparing surgery, request on-call gynecologist for input. That means in that case, you need to do a laparoscopic surgery and you need to do the ovarian sparing surgery. So as I told you in the torsion, you need to do the detorsion with or without ovarian cystectomy. There is no role of nowadays of ovarian removal, that is oophorectomy. Okay, so I again repeat, in case of asymptomatic or any other symptoms with an ovarian cyst in children and adolescents, you can do a ultrasound first. So in that case, if it is a simple one, according to the size of the tumor, you have to manage. If it is less than 3 centimeter, there is no role of management. If it is 3 to 5 centimeter, you need to rescan in 3 months for reassurance. If it is 5 to 7 centimeter, if it is asymptomatic, just to do the rescan in 3 months. If it is resolved, so it's okay. But if it is persistent, then you can do the further investigations. But if it is symptomatic, then you can do further investigations like tumor marker or MRI. Okay, and if it is a simple cyst but the size is more than 7 centimeter, so in that case either you can do the rescan in 3 months or you can do laparoscopic ovarian cystectomy, anyone. But if you see that it's a complex cyst, so most of the cases complex cyst can be germ cell tumor, so you need to do a tumor marker testing like alpha fetoprotein, HCGs, LDH, and CA125. And if MRI is required, you can do that. And if there is no suspicion of cancer, there is no role of intervention. But if you see a patient is symptomatic or size is more than 5 centimeter, you can do laparoscopic cystectomy. And after the operation, you need to do a follow up, and you need to inform patients about the nature of the tumors and also her implications on future fertility. But if you suspect it's a cancer, then you need to refer the case to the MDT for further evaluation and management. But if patient present to with in emergency situations like with acute abdomen, you may suspect it may be a torsion. So in that case, you can do an ultrasound if it is available within 4 hours of admissions, or if our clinical condition permit, you can do that. And the main treatment is to laparoscopic surgery. And as I told you, in torsion, there's nowadays there's no role of oophorectomy. The torsion main treatment is to detorsion with or without ovarian cystectomy. That means you have to do preservation of ovary even if the ovaries are necrotic, because many necrotic ovaries can um, spontaneously resolve and restrain their function. So is it clear to you all, or should I repeat these things? Anybody have any questions? Okay. So while we are performing laparoscopy in children and adolescents, there are some anatomical variations. We need to uh, keep it in mind while we are performing the laparoscopy. So what are these things? First is in anatomy. So bladder is intraperitoneal in children. So care with suprapubic. So when we do the suprapubic port, we need to think about that. And if the age is less than 10 years, catheterization can cause urethral trauma. So if we do the catheterization, we will be more cautious on that. So this is the first thing. Thin children will have aorta just beneath the skin. So careful with skin incision and lift up the umbilicus before incision. So as in case of thin child, aorta will be very close to that. So while we are doing the port, we need to be more cautious and we need to do the careful skin incisions. And while we do the umbilical port, we have to lift up the incision, lift up the abdomen before incision. And pneumoperitoneum is kept at 12 to 15 millimeter mercury for thin adolescents, and for younger children may require 8 to 10. That means low pressure setting you have to keep it. That means for adolescents 12 to 15, and for younger children it's 8 to 10 millimeter of mercury. Fascia is not well developed and prone to port side herniation. Use smaller scope like 2 to 5 mm. Use smaller trocar close to the fascia. Okay, that means that as the fascia in here is not well developed, so there's a high chance of port herniation. And in laparoscopically, we can do a 5 millimeter or more than that, like 7 or 10 millimeter port. So in children and adolescents, we need to do a smaller port like 2 to 5 mm, and we need to use smaller trocar. Keep camera in the port as the umbilical port is removed to prevent omental eviscerations. Keep port open while removing. So we need to keep the camera inside while we are, if you remove the umbilical port, because there's a chance of omental eviscerations. So we need to check that. And avoid the vaginal examination and uterine manipulations in adolescents unless necessary during procedures. So most of the cases, the adolescent girls are not sexually active. So we need to avoid vaginal examinations and uterine manipulations. And in case of anesthesia, be mindful of the effect of interperitoneal carbon dioxide under pressure and limited functional lung capacity. So we also need to think about that things. Okay, so this is all about ovarian cysts in adolescents and children. It's a little bit different from management, and also the natures of the tumors are a little bit different from premenopausal and menopausal women. So in short, if we revise this one, so it's the most of the cases it's benign in natures, and most of the cases it will resolve spontaneously. And this type of tumor is quite common, or the peak incidence occur in first year of age and also around the time of menarche. Okay, and majority of the cases patients are asymptomatic and it can be found incidentally, and the risk of malignancy is very less. Okay, so in case of neonatal ovarian tumor, and it's the commonest if you see any abdominal cyst in the female fetus, so it's the commonest cause, like ovarian cyst is the commonest cause of abdominal cyst in female fetus, and it's mostly occur in the third trimester, and it's usually unilateral, and it's usually occur due to hormonal responses like any fetal gonadotropin hormone, maternal estrogen, and placental ACG hormone. And it can be complicate that is like it can cause rupture, torsion, hemorrhage, and even compression of the surrounding structures. And this you need not to treat this ovarian cyst, only you need to do a serial scan, as because majority of the cases after 2 years of age this can be spontaneously resolved, because in that time there will be no hormones like maternal estrogen are not in there, so it can be spontaneously resolved. So only you have to monitor the case. In case of benign ovarian tumor, you can see the benign majorities are benign, and among the benign tumor 60% are the simple cyst. Okay, and malignancy is very rare, like in 4 to 16% of the cases it can be malignant. And if it is a complex one, so most of the cases these are the germ cell tumor, and among the germ cell tumor the most common tumor is mature cystic teratoma, that is dermoid cyst. It can occur in 55 to 70% of the cases, and mostly occur in 6 to 15 years of age. Okay, and among in the malignant ovarian tumor, the most common, like in 50% of the malignant ovarian tumors, are juvenile granulosa cell tumors, and it can be also a malignant ovarian germ cell tumor, like in 1.5% of the cases. And among them, one third can be done disgerminoma, one third can be immature teratoma, and one third can be embryonal tumor, endodermal sinus tumor, choriocarcinoma, or mixed. That means other type. Okay, and it's mostly occurred in the first 2 decades of life. Okay, and these juvenile granulosa cell tumor, as you know, that they release estrogen. So the most of the cases they present with pseudo precocious puberty. Other than estrogen, it can also release androgen. So sometimes they can also produce some androgenic features like clitoral enlargement, hirsutism, deep voice, irregular periods, and amenorrhea. And as I told you, most of the cases, these are asymptomatic. 30% of the cases, they can present with pain. Also, they can present with other problem like distension, pressure effect, torsion. So all these can occur, and torsion usually occur in 9.5 to 12.5 years of age, and mostly on the right side, as because of mobile cecum can permit the movement, and on the left side, as there is a fixed sigmoid colon that prevent any movement. And these are the differential diagnosis. We need to rule out these things. And for the investigation, so first line investigations is transabdominal pelvic ultrasound. If the patient is sexually active, in that case you can do a transvaginal. And this transabdominal pelvic ultrasound, its sensitivity specificity is quite high. And if you suspect it's a complex ovarian cyst, in that case you can do a MRI scan also. Okay, and according to the transabdominal scans, this international ovarian tumor analysis, you can be divided as a benign, or you can be classified as a malignancy one. And if patients present with any sign of precocious puberty, you need to do the hormonal profile like FSH, LH, estradiol, and thyroid function. Okay, and these are the tumor markers. You can also do that, and this is in short of management. So if you see that if any patient other than acute emergency, like in other than acute abdomen, if patient present with any ovarian cyst, you need to do trans abdominal scan to rule out the nature of the tumor, whether it is simple one or whether it is a complex one. So first you have to rule out these things, and in case of simple one, according to the size of the tumor, you need to do the treatment. If it is less than 3 centimeter, there is no role of treatment. If it is 3 to 5 centimeter, in that case, just do the rescan in 3 months. If it is 5 to 7 centimeter, if it is asymptomatic, just do the rescan in 3 months. If it is symptomatic, then you need to do further investigations like tumor marker and MRI. But if you see that the size of the tumor is more than 7, in that case, either you can do the rescan or you can go for ovarian cystectomy. In case of complex one, as you know that most of the cases, these are the germ cell tumor. So you need to do the tumor markers, or if it is required, you can do the MRI. And if you see that it's a benign in nature, but it is symptomatic, size is more than 5 centimeter, you can go for laparoscopic cystectomy. But if you suspect it's a cancer, then you can go for gynecological oncology referral and for MDT review and further management. But in case of emergency of acute abdomen, if you suspect that is a torsion, so the main management is to go for laparoscopy, and you can do the detorsion with or without ovarian cystectomy, but there is no role of oophorectomy. Okay, and these are the surgical tips you need to remember while we are performing laparoscopy. So anybody have any question in here? Okay. So anyone interested to try to answer this CPD? If anyone interested, she can unmute your mic and try to answer. Is that just a CPD we need to uh, do? Dr. Nidhi, can you unmute your mic?
Yes, ma'am. Hi, ma'am.
Yes. Yes. Hi. How are you?
I joined late. I can try. These are CPDs. What is CPD, ma'am?
CPT, these are the questions you can see in the talk, the last page. You have to answer just like true, false.
Okay.
It's not a single based answer. You have to just
True,
answer
false.
whether it's true or whether it is false. So you can try.
First is false. First one is false.
Why? Why it's false?
It is mature cystic derm. It has to be, there are more chances of malignant in them, right? Right.
No. In the ovarian cyst in children and adolescents, most common,
Hmm.
most of the tumors are benign one. But in
Benign
about
one.
60% of the cases, these will be functional.
Function.
Okay,
Hmm.
that's why. And the second one,
Right.
whether it's true or false, who can answer? Dr. Parveen?
False, because it is 4 to 16%. Yes, malignant.
Yes, very good. Yes, it's 4 to 16%, so that's why it's false. Okay, so you can try also these two questions. First, to read the
With re-
question.
yeah, with regard to clinical presentation of ovarian cyst or tumor in children and adolescents, pain is unusual symptom. No, pain is the usual symptom. It is
Can you
false.
remember the incidents?
No, doctor, because I joined late. I joined at 4:15 only. Just now
Okay,
I saw telegram.
okay. So it's 30% of the cases pain can occur. So it's quite common symptoms. Okay, the
Yeah.
next one.
And Meek syndrome is the recognized presenting feature of rare tumor in this age group. I think so. This is also false.
No, it's true because in this age group, mixed
Meek syndrome is
and granular cell tumor, so it's rare.
uh,
In this group, these symptoms are rare.
rare. So it is true.
Yes. So it's true.
So,
Okay.
Dr. Juma, I want to ask, you will have this recording, no? Because I missed my
Yes.
most of the. Okay,
Yes.
thank you.
I will also provide you the recording. Okay. Dr. Bushra?
Yes, Apu. How are you?
Yes. How are you?
Yeah, I'm fine, Apu. Thank you.
Okay. You can try this question.
Okay, Apu. I'm reading. With regard to investigation in children and adolescents with ovarian cysts, the tumor marker associated protein is raised in immature teratoma. Apu is true.
Yes, you are correct. Then?
Okay. Then lactate dehydrogenate is a tumor of dysgerminoma. I think this is also true.
Yes.
Am I?
Correct.
Okay. Then number 7, International Ovarian Tumor Analysis Group tools have 90% sensitivity to differentiating the between benign and malignant lesion on ultrasound scan. About it's 94%, I think, sensitivity.
Yes, so
It was
overall it's true because 90% is also correct. So
correct,
it's
no?
also
Okay,
true. Yes.
true, no?
So
Okay,
very good.
thank you.
Okay, so
Thank you.
who is next? Dr. Nilima?
Yes. Regarding management of ovarian cyst in children and adolescents, a 7-year-old with an incidental finding of a simple ovarian cyst measuring 4.5 centimeter should be reassured and discharged from care. It's
So there's
4.5
two features.
centimeter should be
Simple and
reevaluated.
its
So
height is 4.5 centimeters. So what will be your management?
she should be called after 3 months for reevaluation because
Yes,
less
very
than
good.
3.
So yes,
So it is
less than 3, there's no role of further follow-up, but more than 3, that means 3 to 5, you need to do the follow-up. So it's false. Very good. Then
Point 9. Chemical peritonitis secondary to intraperitoneal dermoid cyst contained spillage is a significant risk when considering laparoscopic ovarian cystectomy as opposed to laparotomy. Yes, it is true.
yes. And what's the percentage of chemical peritonitis?
0.3% around.
Yes, yes. Then
Point 10, detorsion has been shown to be followed by resumption of circulation and ovarian viability in more than 80% of cases. It is true in most of
yes,
the
it's
cases.
true. Yes, very good.
Thank you.
Okay, so who's next? Dr. Priya?
Yes, ma'am.
Yes.
I just joined for the last 3 slides. I'll try.
Okay.
With regard to malignant ovarian tumors in children and adolescents, juvenile granulosa cell type is the most common. True?
Yes, very good. Because 50% of the cases, malignant ovarian tumor in children and adolescents are juvenile granulosa cell tumor.
Malignant germ cell tumors account for approximately 5% of cases. False?
Yes, false. Because incidence is 1.5%, not 5%. Okay. Next.
Okay. Immature teratomas are characterized by the presence of variable amount of immature neuroepithelium. True.
Yes, very good. Because if any teratoma contain an immature neuroepithelium, we call it immature teratoma. So it's also true. So very good.
Thank you.
Dr. Ragini? Dr. Ragini, you can unmute your mic. Dr. Roshan? You can first unmute your mic and then try to answer. Don't be scared. Dr. Reva? Dr. Sara? Anyone who interested to answer, she can answer.
Okay, juvenile granulosa cell tumor, 14 R6 cause trauma tumor, true.
Yes.
Seen present before age of 6 years in most cases, false.
Yes. In which ways it's mostly occur?
Around 9 to 14,
It's 6 to 13.
13, yeah. Have 5-year survival of more than 90% of surgical resection only, true.
Yes.
Present most commonly with feature of pseudo precocious puberty, true.
Yes. Why?
Because of estrogen
Yes. Very
hormone.
good. Yes. Very good. Okay. This is the last question. Anyone interested, she can answer. Dr. Safia, you can unmute your mic.
Hello, Juma.
Hello, Appa. How are you?
I am fine.
Okay. So try to answer this question.
I have joined just 3 minutes before. I can try.
Okay. No problem.
Concentrating torsion of ovarian cyst in children and adolescents is more common on the left side. I think this is true.
No, it's false. As because in the left side there is a fixed sigmoid colon that prevent the this mobility, but in the right side cecum is mobile and that all facilitate this torsion. Okay, so that's why the torsion is more common on the left side. Sorry, on the right side.
Thank you.
So it's
Right
false.
side. The mean age at presentation is 15 to 18 years. False.
Yes. Mean age is 9.5 to 12.5 years.
Yes. So most present are acute
Unilateral migrating pain.
Migrating pain. True, this is true.
No, actually the torsion pain will not migrate.
Not migraine, but unilateral pain.
Yes, unilateral, but it's not migrating. Torsion pain will not migrating. It will be fixed on the side of the torsion. It will be fixed. That is only unilateral, but it's not migrating. So that's why it's false.
Oh, migrating. That's why it is false. Yes.
Yes. Yes. Okay.
Thank you.
Okay. Thank you. So thank you all for listening this talk. So very soon we will also discuss another talk. So anybody have any questions? Okay, so thank you all for the joining this session, and I will provide you this recording so that anybody join late, she can listen this today's session. And if you have any kind of questions, you can also ask in your group. And please subscribe our YouTube channel so that if new video upload, you can also see that, because we will give this recording on our YouTube so that you can see that. Okay, bye.
Bye, Apple.
Bye.